signing in. All right, you're all set.
All right, so thank you. First off, Eva, thank you for letting me come in just to spend a little bit of time with you guys this evening. Eva asked that I share a little bit of my background. So I am born and raised in Cincinnati, Ohio. And right out of college, I went to Pennsylvania. I went to Villanova University, and it was so far away from home. I got very homesick and I came back. And I actually, just to give you an idea of me, because I know I was coming back, I actually blew off a final chemistry exam and came back to Cincinnati, was here for a semester and decided, yeah, this isn't working, and wanted to go back. But having done that, I messed up my whole 4 rotation. I got completely out of sync with everything. And so after another year at Villanova, I said, this is not working. And I actually came back to Cincinnati. I went to and applied to Jewish School of Nursing at that particular time. And what I did not know is that within a year, they had closed the doors. I was not accepted into the program, but I didn't know at the time why. And so, of course, that does a big, huge hit to your ego. And I decided, screw it, right? So I'm going to do something else. So I had worked as a secretary just to have a job. I got married, and my husband, you ever get a chance to meet him, on our first anniversary, he recounts the fact that I said, honey, I want to stop working and I want to go to nursing school. I thought he was going to fall over out of his seat. However, I applied to Good Samaritan School of Nursing, 3-year program at that time, and it's a diploma grad program. And so I went through the entire diploma grad program. I graduated with no issues, had 2 children, by the way. I've been told I'm still there as the record of having 2 kids in a 3-year program. Started working at Good Samaritan Hospital. I worked on the adult rehab unit. And while I was there, I realized, you know, if I want to do anything at all, I really need to have my BSN. But it was working on that unit that I had a CNS, and there wasn't a whole lot of CNSs at that particular time, who started taking me around to see different things with patients. I was on the stroke team, and everybody was looking at a specialty. And at that time, I was looking at rehab as a specialty and realized I even got the book, and this is just not really my forte. And so she started talking about wounds, and there was no WOCN, which is wound ostomy and continence nurse. It was an ET nurse, which is endostomal therapist. So all they did was ostomies. I thought, I don't want to do just ostomies. So I went ahead and got enrolled in an RN to BSN program at the College of Mount St. Joe. And because of all of my lovely credits that I had from Villanova, and then of course from Good Sam, I was able actually to complete the program in 14 months. And so I did graduate with my BSN, and I was working, having children. I decided that working in a hospital at that time was not conducive, and I went into home care. I was in home care for 10 years, had a couple more children. I have 4 total. And while working in home care, I thought, you know, this is all nice, but I really want back in a hospital setting. When I was doing my rotation in pediatrics, I was actually told by my instructor that I had no business in pediatrics. I took them to heart. I just absolutely love those entire babies, and I was told I couldn't maintain the professional distance. However, I decided, you know what, that really is my love, and I applied at Cincinnati Children's Hospital Medical Center. I got employed. I worked on the rehab unit for about a year and a half, and they started going through their magnet journey. And in their magnet journey, I knew very well that wounds, pressure injuries, right, is a part of that. I went to the individual who's in charge of magnet and said, what are we doing about this? And I used this quote: children do not get pressure ulcers. That's what they were called at that particular time. And I was seeing them on the rehab unit, and I knew that wasn't accurate. So I went on ahead on my own and looked again and said was no longer an ET nurse. It was a WCN, and I went and paid for it all and got my WCN. It was identified that the hospital needed a WCN, but they really wanted a nurse practitioner. And this is about the time that I met Eva. So I applied for the position. It got an ambulatory, and Eva was working there in an ambulatory setting. And I did, they realized that they weren't going to find a nurse practitioner. They changed the job for an RN, and I was able to obtain the position. And that was in 2004. And we went on ahead and developed an entire pressure injury prevention program for the hospital. I went on ahead from there because I was told they were going to hire a nurse practitioner. And since I had started and developed that program, I thought, it's my program. So I went on ahead. They did have a cohort, and I went back to school again and became a family nurse practitioner out of NKU. So I am, thank you. I am a family nurse practitioner, and a few things changed at the hospital as it tends to do, right? And so after being there for almost 10 years, I went ahead and left Cincinnati Children's Hospital. I was working in and out of nursing homes as a nurse practitioner, seeing adult patients with wounds, and my love and calling truly is pediatrics. And somebody reached out to me from Children's Minnesota, and I thought they have lost their ever loving mind. However, I went to Children's Minnesota and was there for 6 years. While at Children's Minnesota, I went to my first National Pressure Injury Advisory Panel conference. And there was an individual who was out of Indianapolis, and she and I knew each other from the WCN Society. And she said, Anne-Marie, you want to be on the panel? And I thought, excuse me, what have I done that was enough that I needed to be on the panel? So one of the requirements to be on this particular board is you have to have made an impact, not only at your own hospital, but you have to have presentations and you have to have articles. And I had a few, not a whole lot at that time, but as the story unraveled, when I left Cincinnati Children's Hospital, they had some issues with their pressure injury prevention program, and they reached out to Joy Pittman, that's her name, who is in Indianapolis. And she was actually hired as a consult, and she had looked at my entire program that I had put together. And she says, you know your stuff. We need a pediatric person. Will you, is it something you want to do? The board is purely nomination. You can't call there and say, I want to be on the board. It doesn't work that way. You must be nominated. Joy nominated me, and I was unanimously accepted as a board member, which I can't begin to tell you the incredible honor. But at that first conference at NPIAP, they were NPUAP at the time, Joy introduced me to many of the nurses that are on that board, and they go, Anne-Marie, are you going to get your PhD? And I thought, oh, Lord have mercy. Have they lost their mind? Unfortunately, or fortunately, no matter how you look at it, I am currently in a PhD program at the Catholic University of America. I am a PhD candidate. What that means is that I have all of the required classes behind me and have successfully completed that comprehensive examination. And actually, I believe my grades right now are at summa cum laude. Not summa, it's not summa, it's, what's the next one down? Magna? Magna. So, yep, which is something else in and of itself. I found that I absolutely enjoy research. And so the goal is that I will actually be graduating next year with my PhD. And telling you thank you is not to pat myself on the back, is to tell you that the sky is literally the limit in nursing. If you find a path, and it must be something you're passionate about. I can't stress that enough, because you will not have the drive to follow through if it is not. If you find something that is just in your heart space and what opens you up, you can do whatever you want. I am, it may not look like it, but I am honestly in my late 50s and I'm in a PhD program, finish it out. Never let your age be a deterrent for moving forward. Never let your situation be it. Bring together your supporters, And yes, I did speak with my husband to make sure I had support for doing this. That's very, very important for a relationship, and bring them together. And if it's something you want to do, all I can tell you is you can do it. So that's the whole purpose in telling you my story.
Yes,
And so-
I asked Anne Marie to share you guys her story because I met her in the middle of her story.
Mhm.
And we were both diploma grads and Mount St. Joe grads.
Yep.
And I happened to go to Jewish Hospital School of Nursing. She went to Good Sam. And we started out just like all of you are starting out.
Right.
And you know, she's a nurse practitioner getting her doctorate, and I got my master's, and we both love peds. And so I just want you guys to know that your patients and your families, they don't care if it takes you one time to pass
Yeah.
your boards or 4 times to pass your boards. They just want you to be kind and caring and give them
Mhm.
good care. So, and Anne Marie's going to talk to us all about wounds and staging and all that good stuff.
Yeah. And to back up what Eva just said, I have a very dear friend that Eva also knows, April, my lovely April. So it took her 4 times to pass her boards. She is one of the most conscientious nurses that I know. She has such bad test anxiety. Just take your time. And it doesn't matter. No one needs to know. No one ever needs to know what your cumulative GPA is unless you choose to tell them, nor they need to know how many times it took you to pass the boards. All they need to know is, did you? That's it.
That's
So
right.
you guys can do it.
That's right.
In
That's right.
that, let me go ahead. I need to pull up my presentation, and we're going to talk about pressure injuries. This is honestly near and dear to my life. I love everything about it. Don't ask me why. People think I'm a little weird because I don't know. I am going to show you wound pictures.
Yeah, so we had an NCLEX question a week or so ago. When it dawned on me while you're drawing that up or pulling that up, I'll tell you about it. I
Okay.
think Kashi and Ronald and Kevin, we were all on here together. And it talked about the exposed bone, and was that a stage 3? Was it a stage 4? Was there induration? All that stuff. And it tripped us up a little bit. So that's when my light bulb went on, and I said, "Oh, I've got to call Anne Marie and have her come on and share some thoughts on staging and wound care and sterile dressings and so on." And so I'm really glad that everybody is on here. You've got about 6 or 7 students, so it's great. Perfect.
Perfect. Now, this is not a formal presentation in any way, shape, or form. You want to unmute yourself. You want to ask me a question, please do. You don't have to wait to the end if you don't want to. It doesn't really matter because I'm here for you. All right, so let's talk a little bit about pressure injuries and what are these wounds. So the one thing that I have been doing this for 2004. 2004 was when we started the pressure injury prevention program at Cincinnati Children's Hospital. And what I came to recognize that across just in general, people don't understand when they say pressure injury, that pressure injury is a wound. It is an open wound. And so I want to make sure that off the bat, you understand that within the classification of wounds, there are many out there, right? Abrasion is a wound, pressure injury a wound, there's a surgical dehyst wound. There are multiple. This is just one, in that why it's such an issue is if it occurs and develops within the hospital setting, because you lose money. And that's why this is a big deal. It is considered a safety issue. Oh, I forgot to tell you, I left Children's Minnesota. I'm now at Dayton Children's. So
Yeah, yes.
as you can see, here we go. So I've been at Dayton Children's 6 weeks.
Yes, she just keeps moving up and moving up and moving up and moving up and speaking all over the entire country and world.
I do.
So we're really lucky to have you on here tonight.
Thank you. And it is, there we go. All right, so let's talk about a pressure injury. So there are multiple names. Most people think of pressure injuries in the community, they think bed sores. Bed sores was something that was actually deemed in Florence Nightingale's time. She called it a bed sore, but they have been around literally thousands of years. We can go back to Egypt time and we can find what they're talking about is a pressure injury. The changes that was made from pressure ulcer, which is what you probably have known, was actually in 2016. NPIAP, which is the board that I am on, is the governing body in the United States that determines everything related to pressure injuries. And that is when it was changed. And I'll explain why. So a pressure injury definition, this is actually straight off the NPIAP website. It is localized damage to the skin and underlying soft tissue, usually over a bony prominence, or related to a medical or other device. The injury can present as an intact skin or an open ulcer and may be painful. So this right here, when it says intact skin or open ulcer, this is why it got changed to injury, because the intact skin does not denote an ulcer. An ulcer is an open wound. And so when they looked at it, so it's similar as if you've got a kidney injury, right? There are many different types of kidney injuries. It's the same prominence. It is an injury to the skin. So that injury occurs as a result of intense and or prolonged pressure, or pressure in combination with shear. The tolerance of soft tissue for pressure and shear may also be affected by microclimate. All that means is moisture, heat and moisture, nutrition, perfusion, comorbidities, and condition of the soft tissue. Etiology. Now, there is actually two different types of pressure injuries. The one that most people think about is immobility, which of course is any body part, particularly over a body prominence, your sacrum, your coccyx, your heel, the posterior aspect of the scalp, because it is in a stationary position for a long period of time. You're not moving. For whatever reason, you're just lying there and you're not moving. Now, times for repositioning, and this is something you will definitely get once you hit whatever setting you will be working in. They would talk about repositioning. And that can vary depending on the surface that the patient is lying on, the type of headrest. It also can vary if you work pediatric versus adults. Right now, the recommendation is that a patient is to be moved every 2 hours. Medical device related pressure injury. So these are pressure injuries that result from the use of a device designed and applied for diagnostic or therapeutic purposes. The resultant pressure injury generally conforms to the pattern or shape of the device. So this injury is staged using the same staging system. And the medical device related pressure injuries, it became much more prominent. I started talking about them in pediatrics because the medical device related pressure injuries is actually the #1 type of pressure injury within pediatrics. You do not see as many immobility, definitely not over the sacral and coccyx area or heel until they hit teenage years. But within the adult or geriatric population, immobility is your #1 cause of pressure injuries. We talk about stages. So stages are, it's given related to the amount of the visible damage to the skin structure. So what do I mean by that? The stage is not linear. It has to do with the damage that is visible, and I can't stress visible enough. If the damage is unable to be visualized, you cannot stage it.
That helps. That helps.
Right.
Okay.
And the damage can deteriorate further, right? But once it has reached a high level of destruction, that stage cannot be reversed. And of course, always related to destruction. What do I mean by that? So let's say that you've got a stage 3 pressure injury. We'll talk about that in a minute. And as it starts healing, and you can see the depth, and now we've got some really good granulation tissue. It's nice and healthy. You cannot say this is now a stage 2. It doesn't go forward. It doesn't go backwards. The stages are given related to the extent of the damage. So this is a stage 1 pressure injury, non-blanchable erythema of the intact skin. So it is intact, it is not open, it is red, it tends to be warm. A lot of times you'll have those temperature changes. It can be firm, but it is always red. And that's where I want to stress that, because if it becomes purple or maroon, we're looking at deep tissue injury, and that's something very different. A stage 1 pressure injury is typically top down, which means there's something pressing against the top of it. It doesn't reach the bottom layers of the skin, and it usually will resolve within a couple of weeks. It'll get lighter and eventually just go away. The picture that I've shown you, as you can see, this is a baby. I've got baby pictures because I'm pediatrics, and you can see, right? That's a lock on an IV. That IV was put in, and that was pressed against the baby's skin. And you can see that it's a medical device related because the perfect shape. That shape of that lock is exactly what is the shape on the baby's foot. But the skin is not broken. In a stage 2 pressure injury, we have partial thickness skin loss with exposed dermis. That exposed dermis sometimes is very difficult to tell. What I like to say is that a stage 2, if you were younger and you fell down and you skinned your knee and you got that top layer just sheared off, that's your stage 2 pressure injury. It can be viable, pink or red, moist. It may also present as an intact or ruptured serum-filled blister. That is very important that it is serum-filled, because again, we'll talk about it in a minute. All the rest of this in the definition is telling you what it is not. You will not see adipose tissue. You're not going to see granulation tissue, slough, or eschar. So this is all telling you what it is not, but what it is just that top layer of your epidermis has been sheared off.
I have a question about that one.
Sure, let's go back.
How do you differentiate between a friction blister and a pressure injury blister?
Okay, so let me go back a minute to our definition, okay? Injury is a result of intense or prolonged pressure in combination with shearing. Originally, this definition had friction in it. So friction is that constant rubbing. There's not necessarily pressure that you push down, but that's that constant rubbing. So when you're talking a blister, so if we're looking at a blister, right, because a blister can be caused by pressure, a blister can be caused by friction. That's when it is up to the nurse to do some, a lot of investigating to determine that actual cause. If you've got a patient and they're out there and they constantly rub their elbows, constantly moving, constantly rubbing their elbows, or their foot is going, and so you've got that complete rubbing against their heel constantly, that would not be considered pressure. That would be considered friction. Does that make sense?
Yeah, so really it's kind of a situational. It can vary patient to patient, and that would be up to the wound nurse's discretion.
It would be up to the wound nurse to make sure she's done her due diligence to find out the cause.
Okay.
So I can tell you within my practice, if I cannot say with 100% certainty that it was caused by pressure, I will not call it that. I would rather err on the side of wrong than err on the side, and then we are calling things what they are not.
Okay.
So that's my personal practice.
Excellent. That helps a lot. Excellent. Okay.
That's a great question.
Great
It is a
question,
really
Amanda.
great question.
Yeah.
A stage 3 pressure injury is full thickness. So if you notice that partial thickness is epidermis and dermis, full thickness goes down into the subcutaneous layer, and we're looking at adipose tissue. So like it says here, so it is full thickness loss of skin in which adipose or the fat is visible in the ulcer, and granulation tissue or eboli, which just means rolled edges, are present. You can see slough, you may see eschar. However, you have to be able to see the depth of the wound in order to be able to stage it. So unfortunately, this cute little baby was on a blanket roll. Blanket rolls are a no-no in pediatrics because of things like this, laid on it way too long. And as you can see the subcutaneous layer, you can see that adipose tissue, but I can also see the depth. I'm not going any deeper than into that subcutaneous layer. And so this here is a stage 3 pressure injury. Now, stage 4, we are going as far as we can. And so now I can either visibly see or I can palpate fascia, muscle, tendon, ligament, cartilage, or bone. You might have slough within the wound bed. So like in here, although there's yellow, there is adipose tissue in there. You can also see on the bottom one, there was some slough there. Slough is dead tissue. Eschar is dead tissue. When you have moist dead tissue, it has a yellow hue to it. When you have dry dead tissue, it's black and leathery and it's eschar. So on a stage 4 pressure injury, you have to see something. The picture is actually a young man. He was 13 at the time. He lived in Somali, and he ended up catching TB, and it developed into what's called Pott's disease. It just means for him that it got into his spine and it actually paralyzed him from the waist down. And so he ended up a paraplegic because of it. In the tents that they lived in it was a refugee camp in Somali. They always sat cross-legged on the floor, and he couldn't feel anything. He's a paraplegic, so he sat cross-legged on the floor. He created wounds on the sides of his thigh, which is what you're looking at, where his heels dug in, because he has no sensation. And because that wound had gotten infected, he was actually, their family, there was, I think there was 8 at that particular time, 8 children, and they were flown to Michigan. And in Michigan, they found out that there was a large Somali population in Minneapolis. And so they got flown then to Minneapolis, and that's how I met him. If you look close, I know it's a little difficult to see, within that wound bed, there is roughness. I don't know if you can see kind of that red, there's roughness within there. That is the bone. That is the trochanter that you're looking at. Underneath there on the surface, you see where the scar tissue is around. It's almost completely around that wound. If I took my finger, which I did, those are my hands, underneath that wound, it is what they call undermining. The whole thing is stripped underneath there. And so every time he moved his leg, because the bone was exposed, it would go completely around and it broke all of the tissue that was underneath there that held everything together. So he ended up having surgery to get that fixed. But this is a stage 4 pressure injury because I can visibly see the bone that is there. There are times over the coccyx bone may not be completely exposed. There is a layer left of soft tissue, but I can feel it. That is still considered a stage 4 pressure injury. Anytime you have that bones with everything else supporting its structures gone, you are very, what's the word I want? Susceptible to getting osteomyelitis, which is an infection in the bone. It's always something you have to take into consideration anytime we're down near the bone.
So how would they go about surgically repairing this? Would this be a graft? Or would this be a kind of a pulling the skin together, like what? And then how does it heal if they close it? I'm just being a student here.
No, that's perfectly fine. So we tried the wound vac. I tried the wound vac for several months. We got some closure on it, but because of the movement, we could not. What we ended up doing was putting in a porcine graft and then closing it because we needed a structure inside for the soft tissue to grow into. And so a porcine graft was actually put in it, and then the plastic surgeon actually closed it together. And then we completely immobilized his knee. We put him in a knee immobilizer, which goes, if you ever seen it, there it's in a V shape that comes up. And so you strap the legs on both sides. It's Velcro strap. You strap him to the knee immobilizer because we didn't want his hip to move. And he was like that for a couple of months, and we didn't have any issues. And that at that point, we sent him home.
Wow. Wow.
He is one of these little kids. He's near and dear to my heart. When he got to Children's Minnesota, he still had a very thick accent, and he talked in broken sentences, and he always go, Anne-Marie. What? Yes, how can I help you? And we, in order to increase protein, because rice is a staple for their diet, but for anything to heal, you've got to have large amounts of protein because you need the collagen. The collagen is what creates the tissue when we're trying to heal any type of a wound bed. Other thing, well, I'm going to tell you a side note here. Stage 1 and stage 2 pressure injuries heal very well, and usually you won't even know that they were ever there. They just heal nicely and they go over. However, once you've gone into the subcutaneous layer or below, you have to heal by scar, which is secondary intention. And that scarring never has the tensile strength that it had previously. And so if anybody walks into your institution, comes into your institution, they are never to lie on or have anything put on a scar of any type of a wound because it is prone to re-breakdown.
Oh, excellent, excellent. And when you say a porcine graft,
Yeah.
that's not from the patient. That's from, is that like a man-made graft, correct?
It was from a pig.
Pig. That's what I was hesitant to say it, but that's porcine. That's what I was thinking. So
It was pig, and
Yep.
because they are Somali, they do have restrictions related to pork, and we made sure that the family was okay with it before we went forward.
Yep.
So we were very conscious about their cultural, and what was important to them, and made sure that they were okay with that before we move forward.
That's what I was thinking.
Yep.
Thank you.
You're welcome.
Excellent.
So this is what is considered an unstageable pressure injury. So unstageable pressure injury can only be full thickness skin or tissue loss. So let me say that again, and I'll explain why. It can only be a 3 or a 4. So a stage 2 pressure injury, if we talk again about that, it's like if you skinned your knee. What happens is the body rushes in and it brings in all this fluid and all this awesome stuff in there so that you can heal it up and heal it quickly, and then it dries and you have a scab. A scab I can pick off. A full thickness slough or eschar, because this is dead tissue, it is still attached. You cannot lift it off and take it away. The first time I had ever seen eschar that had been left intact, somebody had it was at Cincinnati Children's Hospital. They had a pressure injury on the back of their head, and it had been on there for so long that the edges, I could get underneath the edges, but I could not completely pull it off because it was still attached in the middle because it was healing. So that's very important to recognize between the two what you're looking at, because sometimes eschar does look like a scab, but they're very different in how the body heals itself. Okay. So when we've got an unstageable pressure injury, it just means I can't stage it. There was somebody many, many years ago who thought that unstageable was an actual stage. It's not. It is not considered a stage. It just means I can't see the depth. I don't know how much damage is there, and so I can't stage it. But it will always be a stage 3 or it will be a stage 4. I'm going to make a small comment at the end of the definition here. It talks about stable eschar, which is dry, adherent, intact without erythema or fluctuant on the heel of an ischemic limb. It should not be softened or removed. This statement is related to someone who's got arterial disease. It does not apply to pediatrics, and not 99% of the time it will not ever apply to pediatrics. But that stable eschar is a biological dressing. If you take it off on an individual who has arterial disease, they do not have the blood flow to heal it. And you've created an open area which is very prone to infection. It is actually better to leave it intact and act as a biological dressing until or if drainage starts coming out of it, and then they get a whole different ball game. But I just wanted to make.
Is that what you see then in diabetics with
Yes.
poor circulation,
Yep.
neuropathy, things like that? And you think,
Yes.
why are they leaving all that on their feet, and why is it looking so horrible? And it's purposeful, correct?
It's purposeful. And we
Purposeful.
will actually paint it with betadine to hopefully prevent infection, because it's dead and bacteria love anything that's dead. So if you paint it with betadine, which is an antimicrobial, the goal is to keep that eschar intact and to prevent infection.
Excellent. Okay. I'm learning all kinds of things. I didn't know why we left it on. So
Okay. Deep tissue pressure injury. This was a big to do in the wound world for many years until we figure out what in the world is going on. It is persistent, non-blanchable, deep red or maroon, purple discoloration. So I like to say eggplant. It looks like eggplant. That's how deep that purple is. Now, within pediatrics, you can have variations of that. I love my pediatrics because it will lighten up many times and go away. However, in the especially geriatric population, if you get this color, it typically is not going away. And about 95% of the time, you will have a stage 3 or a stage 4 pressure injury. This kiddo here on the bottom, he was a patient at Cincinnati Children's Hospital. He was in the operating room, I believe it was like 12 hours, and he came out looking like this. And I'll never forget it, because we had just hired another wound nurse, and she came from the adult population. And she looked at me, she goes, Anne Marie, that's going to be a stage 4 pressure injury. I said, no, it's not. She goes, there are already stage 4 pressure injuries when they look like that. I said, in your geriatric patient, all we ever got was, see those blistering, those blisters opened up and he healed up beautifully and never went any deeper. And that's the biggest difference right there between your pediatric patient and your adult patient. So with this, and you were talked about earlier that a stage 2 is a serum filled blister. With a deep tissue injury, it's a dark wound bed or blood-filled blister. The reason the blood-filled blister is that the blood supply is in your subcutaneous layer, and so is your hair follicles. Anyone who has had a stage 3 or a stage 4 pressure injury on their scalp will always have alopecia, because you have killed the hair follicles that deep. And it's the same thing here. You will have killed some of the blood vessels, which is why it ruptures and goes into a blood blister formation. It is persistent, non-blanchable, deep red, maroon, purple discoloration, and it will have the epidermal separation. And that's what the blisters are, is that epidermal separation.
And that happened after a 12-hour surgery
That was a 12-hour surgery. Yep.
for a patient, and with the positioning during the surgery.
Yes. And so now this has been, I mean, we're talking now, what, 10 plus years later, there is a lot that has changed within the OR setting to prevent these.
I'm sure. I'm sure.
Yep. So this is a deep tissue injury. A mucosal membrane pressure injury. So currently, when it is mucosal membrane, because it's found on the right, pressure injury is found on the mucosal membranes, usually it's always a device related. And due to the anatomy of the tissue, these ulcers cannot be staged. The tissue in the mucosal is very different than our normal skin structure, and so we don't stage these. We do have a gentleman, he is actually a physician, he's a wound physician on NPIAP currently, who has been working with a urologist to see whether or not we could potentially find a staging system for these. As you can see, this is something in pediatrics is very common, which I wish it wasn't, but it is, in that a Foley catheter actually breaks through the entire urethra of poor little boys. You usually see them there or from ET tubes. So those who have been intubated for a long period of time, you can see that on the inside of their lips.
Yeah, and this can happen in peds and adults. We do
Yep.
see it in the Foley catheters with kids. We had a couple on my unit, and I myself had a surgery that was like 2-3 hours long, and they had the tube down, and the way the tube was positioned, I lost sensation to my tongue, and it was gone for almost 2 months. Sensation to half of my tongue and part of my swallowing, and it took 6 to 8 weeks for it to completely come back, and it was from the pressure from the
Yep.
ET.
Yeah, so it is important. I live and breathe this, and I realize once you start in your first nursing job, it seems extremely overwhelming. The easiest way into dealing with pressure injuries improving if you instill prevention measures right away into your practice, so it doesn't feel as if you're doing one more thing. And there is a really easy way to do that, but that's not what we're talking about today.
You can share if there's an easy way to do that. It's fine.
It has to do when you're doing your skin assessment. You think right away, where are the device hitting and what do I need to do to stop that device from hitting? You just think it as you're going along with everything else. You're looking at your lines, you're looking at your IV site, you're looking, is the hub pressing against it? Well, then I'm going to put something underneath it. It just becomes something that you do automatically. And that is one of the greatest things about nursing. Eventually your critical thinking skills just become so attuned that when you walk in that room, you can do and glance right away a full skin assessment. So you'll get there. So the biggest thing that for me is the takeaway is that a pressure injuries are caused by pressure. If you cannot find a source of a pressure, don't call it a pressure injury. Always use your critical thinking skills to find the source of pressure. Same thing, prior to calling it wound or pressure injury. And the number one prevention measure is to offload, which means you either move that person or you move that device. Get it off of the area that's been through for a long period of time. Any questions before I move on?
Wow. Come on, guys. What do you guys think? Thoughts? Did you learn something? Ronald, Destiny, Shante, what do you guys think? I know you guys are there.
Yeah.
It really kind of cleared things up for me. I think we had a little bit of someone teaching information, getting things flip-flopped. And I know for, the people that I went through with, we swore that a stage 3
Mm-hmm.
I think was like visible muscle, and then a stage 4 was visible like bone, tendon, ligament.
Mm-hmm.
And that's not right. But I remember we had gotten a question on one of our HESIs and we all got it wrong. And we're like, come on, we all knew this. But whoever had said it wrong. So this
Yeah.
really, the way that you had it spelled out really cleared that up for me.
Good.
Excellent, excellent, excellent. Thank you, Amanda, for sharing that. Thank you.
The difference between the pressure injury and the friction,
Mhm.
that really helped because you could get those two mixed up.
Yes.
So I'd like that information. Also with the E-shard, just to know in the field not to remove that and to leave it there because it's still healing is, I think it's very good to know
Mhm.
because it could be mistaken for a scab and you might just want to pick it off or pull it off, but it's still healing. So
Right.
do that.
Awesome. Thank you, Destiny. Excellent. Okay, I think Anne Marie might have some more for us, right?
Sorry about that. That's my little guy barking.
No problem. They're used to my little guy barking, so they're used to Ozzy barking.
So Eva asked me to talk about a sterile dressing. So we're going to go through some of the steps related to a sterile dressing and also the procedure and purpose of it. So I can tell you right now off the bat, it is a rare thing within wounds itself that you ever do a sterile dressing. And the reason for that is that it's open. You will find bacteria. If you find bacteria in any care setting, you have to treat. And what we don't want to is overuse antibiotics because there are a lot of topical wound treatments that we can use and not have to introduce antibiotics because they do have their own side effects, especially in pediatrics or geriatrics. We don't want to go down that road. Okay. So the whole purpose of a sterile dressing is to not introduce bacteria. That is the whole reason somebody would want it done sterilely. Hey, Rudy. So prior to any procedure, of course, we would pre-medicate the patient if it's appropriate. Clean off your surface. Whatever is your surface that you're going to put your sterile field on, you get those lovely Sani wipes out and just clean the whole thing on. And then stress at home, perform your hand hygiene. All right, nice clean hands before we start. So some of the safety considerations, you want to make sure that you have educated your patient or the family, both, on the purpose of why are we doing this? You know, why does it have to be sterile? And the reason we are trying to prevent any type of contamination. Put on your appropriate PPE for your procedure and make sure you have reviewed your facility's policy to ensure that you're following it. Those are all very important steps here. And depending on what's going on and what you're doing and why you're doing it, well, you want to get verbal consent. You don't need to have it written, just to make sure that, you know, the patient and the family is okay with where you're going, what you're going to do. Okay. So when you're doing any type of procedure, sterile procedure, all of the objects on your sterile field must be sterile when you put them on it, and they must remain sterile. So if you have a package that is torn or it's expired, you cannot use it. If an object accidentally gets dropped on the floor, you cannot use it. If anything, if it becomes, I already said that, non-sterile when it's touched by a non-sterile object, you can't use it. It's all making sense. Sterile items that are below the waist or items held below the waist are considered to be non-sterile. The reason it has to do with the waist is you can't see everything that's going on, right? Because you were up here looking, it should be right in front of you. Anything that falls below, you don't know if it accidentally touched something that was considered non-sterile. And so it doesn't belong on your sterile field.
And you guys, I was told that somebody had that question on their NCLEX, that anything below the waist was not sterile. And so like, I was like, oh, you really had that? So they had it on their NCLEX. Okay, so it's not something you think about, right? So anything below the waist is considered not to be sterile. Okay, sorry to interrupt you.
No, please do. Sterile fields must always be kept in sight when you are to be considered sterile. So the easiest one to think about is a sterile procedure is if you're changing a PICC line dressing, or if you're changing any type of central line dressing, those are all done sterilely. So you want to have, usually it's a bedside table, you clean it out and you're going to put your field in front of you. That typically stays to your side, so you can have it in your peripheral vision at all side times while you are performing the dressing change on your patient. You never turn your back on a sterile field. At that point, it is considered no longer sterile because you don't know what has happened. Now, if you're the only person in the room, I'm going to tell you to go and get a new, whole start all over again. But if there's someone in there that's helping and you haven't watched what's going on, you really need to start over. So just keep that in mind. You don't turn your back on it. When you're opening up any type of sterile equipment and adding supplies to a sterile field, you want to take care to avoid contamination. When you're doing this part of it, your hands are not sterile. So if you have gauze, you can pull back the packaging and you flip it over onto your sterile field. Usually you've put down whatever you're using as your sterile field. If it's a dressing change, you may drop sterile scissors, you may drop whatever is your dressing, but anything gets dropped onto the field. Unless, because some things can't, you've got someone in there assisting you. So there are times when if you're doing a central line dressing and you need to clean with betadine, you can open the package, set the package with your hand on the edge of your field, and you've got somebody else later on, once you have on your sterile gloves, who will pick up the package, and then you only take out the betadine. So it is still sterile to sterile, if that makes sense what I'm saying.
Yep.
You don't set up a sterile field. I've seen people do this. They set up a sterile field, they take another sterile drape and cover it over and set it in the back of the room and go about their business. Hour or two later, they come back and they have their field and they go, it's sterile. Well, we don't know that. You don't know what's happened. You haven't been around, you've turned your back to it, you haven't even been in the room. So you are not to do that. The sterile field gets set up when you're going to do your sterile procedure, and make sure you've got enough time to do that, right? Anything that's puncture, any moisture, any tears that passes through your sterile barrier must be considered contaminated, and all sterile surfaces must be dry and intact. Let me do a little qualifier on this. This has been many years ago when we're asked to do a sterile wet to dry dressing. That, again, I haven't done that in years. In order to do that, I need water. I need usually normal saline, right? So I would get out my sterile bowl, and that gets put on the my sterile field, and I would open up a bottle of normal saline. Now, my bottle of normal saline is not sterile once I take it off because it's been sitting out, right? But in the contents are sterile. You have to be very careful when you're pouring that into your bowl, because if it splatters, you got to start all over. It just needs to stay in the bowl itself. I would have dropped on my sterile field Curl-X or whatever gauze that I was using. And then once I was sterilized with my hands, right, I've got on my sterile gloves, I would take that gauze and put it into the water. So just understand, always think sterile to sterile at all times. Again, we're going to drop it on that. The first thing you're going to do once you have everything dropped on it, you will then, you're going to wash your hands, right? And I'm sorry, put on your clean gloves. And with your clean gloves, it is that point you will remove whatever dressing you're using, whatever dressing you're taking off. You're going to take it off with clean gloves. Once you have taken it off, and then you clean the wound, rather, even if it's a line dressing, you're still going to clean the area, and you put all that stuff away. Then you're going to get rid of the debris, you're going to get rid of the dressing, and then you're going to remove your clean gloves. You're going to do hand washing. You're going to dry thoroughly. And now we're going to put on a sterile pair of gloves. It does take a little bit if you've never done it, practice with it because it gets opened up. And you've got these 2 pairs of gloves here, and you're not going to just pick it up because if you pick it up, your hands are not sterile. And now you have contaminated those gloves. You got to get a new pair. The way they come is at the
Cuff, the cuff.
the cuff. Thank you. At the cuff, it is turned down so that you can pick up at the cuff and gently slide one of your hands in and making sure those fingers don't touch, and you pull it back. And then this hand that's now got on that sterile glove goes into the cuff, and you put the other one in and drop it. Now you're completely sterile, right? You've now got sterile gloves on. So at that point, you will apply whatever has been ordered to the wound itself. And you're going to be very cautious that you don't touch the skin, because you touch that skin, you're no longer sterile. If you need to do that, because there are times you have to remember which hand touched and don't do both. So let's just say I need to put, let's just say I am doing a wet to dry dressing. I've cut it off. And this hand, my left hand, which is not my dominant hand, is what I would use to put it in case I accidentally touch the side or touch it around it. And then I can hold that in place if I need to. And then my dominant hand would then pick up the other sterile piece, and that would go down sterilely. And then I could use this one to smooth it out. And so you have to make sure you understand which one is sterile and which one is not. And then make sure again that whatever is your facility policy, some facilities like you to date, time, and initial the clean dressing. Some just want you to document that it was done. Any questions about this?
Wow. Wow. That's a really nice, excellent step by step by step by step. So you guys think about it, right? What do you have on your NCLEX? Sometimes you have those drag and drops where you got to put things in the right order. And we have seen several times when we've been practicing our NCLEX questions that they give you a drag and drop for sterile dressings. And that's how they can test you on your knowledge of what order you do things in. So this was a really nice review for that. Really nice review for that.
Professor Spiegel,
Yes,
will this be posted up for us to see?
yes, as long as Professor Anne Marie is okay with me putting it on my YouTube page. I have a YouTube page that the students go to and they can see the presentations that I've had. So you can think about it in a minute and just let me know. So either that or I'll just send them the link directly.
Okay.
Okay.
Yep.
And yeah, Ronald, I will, as long as it's okay with Anne Marie, I will post it. Okay.
Yeah, it's fine. It's only available to your students, right?
Yes. Yes.
Perfect.
Yes. Okay.
Yep.
Any questions, you guys? What did you guys think? Was this helpful?
Yes, it was.
Yes, it helped out a lot.
Yes, it did.
Good,
Good.
good, good, good. Do you guys have any questions at all before I stop recording and let Anne Marie go be with her family?
No.
Well, I can't thank you enough for coming. This was wonderful.